Okay, I think we're going to get started here. Thank you so much for coming out to our, I think this is the third Partnering Organization Summit. Besides to the folks that I am actually looking at here in the room up at El Centro de la Raza, there are a number of folks on the phone that we'd like, 34 folks on the phone that we'd like to welcome as well. Again, so welcome to our summit. Welcome to my neighborhood. This is Beacon Hill, actually literally almost a block from here is where I live. So welcome to my beautiful neighborhood. Yeah, we are so excited as we continue moving forward. I just wanted to say a few things, so I guess I should introduce myself. So my name is Jeff Sakuma, and I work with for the City of Seattle. I'm the city's representative on the governing board of Healthier here, and I was on the interim leadership council before that, and got to move over to the board when we created the organization. So the work of our board is based on a set of values, and I think it's really important to begin each meeting sort of being very clear about those values, because that truly is what is driving all of our work and our decisions moving forward. As you know, that what we have, or what we are working on, can be somewhat prescriptive from the state of Washington, which we are obviously, which we will adhere to and move forward, but it also allows us the flexibility to really sort of work from what we think are the very, very important things to us, to our community, and to the people that we really want to impact and improve their health and their lives. So I'm going to sort of just call out these values real quickly here to start us off. First and foremost, sort of overriding sort of everything we do is our value around equity. And that you will see in a variety of different ways, but it again, as I often tell folks, that there are values that we put on lists, but I also want to be very clear that a value around equity basically sort of surrounds everything that we do and shouldn't just be sort of on a list, if you will, but looked upon very globally. Our other values around partnership, like all of you are in this room, and the work that obviously will move forward, we want to do together in a partnership. Community, obviously the communities that we serve, and really sort of listening and being accountable to the community. Innovation, obviously that a lot of the work that we would be moving forward is very new to how we sort of have created our silos in the past, and obviously what we'd like to do is to be very, very creative and innovative as we move forward. And then lastly, results. Obviously, though, that's important because that's what we'll be held to in terms of the state, but also really making sure that we are accountable to the people that we have committed to serve. So with that, I'm going to turn this over to our executive director. One of the first tasks of our board was to hire our executive director, and I had the honor of being a part of that hiring committee, and I'm so proud of what we've accomplished in hiring Susan.
Thank you, Jeff, so much. Really appreciate those opening remarks and appreciate your service on our board. We have a rock star governing board, you all should know. I think I've said that in a couple of other meetings, a 24-member multi-sector governing board for the organization. So it's wonderful to have Jeff here. I think we have a couple other board members on the webinar as well. I don't see any of them in the room. So again, thank you and welcome to our Partnering Summit. This is our way of really keeping connected with all of the partner organizations and community-based organizations that are interested in the transformation work that we're trying to do and need to be kept up to date and appraised of what's going on and what the next steps are and how to stay engaged with us as we move forward. So we really appreciate the fact that you're all here and your time today. This side or this side?
Right.
Right. Okay. Let's red, is that bad? Okay, thank you.
It's right across.
So, okay, so let me talk a little bit about today's agenda. So we are going to get an update on the finances and partner agreements. If you were present at our last webinar, you heard us announce that we received our score for our project application. We earned a 100% on our project application, which made us eligible to receive close to $24 million for this first round to help with our project planning and engagement, help support providers have capacity to engage with us and get our 2018 deliverables done. So you'll hear a little bit about what that's going to look like and how to complete what the partner agreements will look like. Then we're going to spend some more time on our Healthier Here portfolio and our strategies for system transformation. So we're kind of staging these summits to kind of drill down deeper and deeper as we think about how we're going to get to implementation. We had great in our application, really strong ideas, well thought out ideas about how to move the various projects forward, and now we have to take those ideas and turn them into action and operationalize them. So we're going to today spend some time focusing on our population approach, and we'll bring you up to speed on where we're at with our thinking around that, and then talk about the evidence-based approaches to system transformation, because Jeff alluded to, we have some guardrails that are part of the Medicaid transformation project and structure that we need to adhere to. And so we'll be going through in more detail what those are and talk about what that means for partnering organizations. One of our first steps and our first deliverables for 2018 is a current state assessment, so we're going to talk about that today. And then we're going to break up into small groups and spend some time drilling down into some of these topics. So that is how we'll spend the day. So here as a reminder, just so you all know what we're driving to and what we are held accountable to the state. And remember that this is not grant funding, so we have to complete our deliverables in order for us to earn money for the region. So that's why we have to be kind of laser focused on these things. The current state assessment that I just talked about, and we'll talk more about that today. We need to identify our strategies for capacity building, the so-called Domain 1 activity. So that includes things like information technology, infrastructure, workforce capacity and development, and capacities to help with the transition to value-based care. That's what fits into that Domain 1 category. So we need to develop a plan and identify where we want to make as a region investments under those three things, again, by June of this year. We need to select or validate, in some cases, our populations of focus and which evidence-based approaches we're going to start to implement. So again, we're going to spend some time on that today. You guys, we're going to be a part of the thinking around that. And then we actually have a requirement so by June, keep this in mind, this is an important date, to engage our project partners. So this is the point in time where you as an organization need to make a decision about, am I going to be an implementing partner for phase 1? Am I ready to start doing the system transformation now? And if so, there's the agreements that you'll have to complete to do that. And then all of this will culminate into and lead to the development of an implementation plan, which is actually due to the state on October 1st of this year. And the implementation plan will really need to detail out what are the activities and the milestones and the timeline for which we're going to implement across the various activities. And so here's just what that looks like in a timeline. These, again, are, for those of you that were here in February, not new slides, these 2 slides, but just a constant reminder to keep grounding us on what is the work and what is our timeline for doing the work. Okay, so I am going to turn the mic over to Tui Hua Lee, who is our Chief Financial Officer, and she's going to give us updates on the finances and the partner agreement.
Thank you, Susan. Do you want the laser?
So today, what I'm going to do is present with you some financial information, and I want to make sure, just to give you an overview, it's going to be peeling the onion a little bit, so just bear with me in the first couple of slides on how we dive into the dollars and then we'll talk about how the distribution approaches and so on. So, where is it? Oh,
It's
there it
here,
is.
but you're fine.
Okay, so for what Susan alluded earlier, we've earned a total of $29 million. And what you see is there are $6 million for what we call the fully integrated managed care, which is the same as behavioral health integration for King County. And then the remainder is about $23 million for project incentives. So today we're going to talk a bit about we're not going to talk about the FINC or behavioral health integration, the $6 million. We're going to focus on the 22.7 or $23 million. Thank you.
I feel the need to make just a little bit of a clarifying comment on this, just so people are really clear. So the fully integrated managed care incentive dollars are dollars that are available to the region because King County decided to be a mid-adopter of fully integrated managed care. This is the financial integration of the behavioral health Medicaid dollar and the physical health Medicaid dollar into managed care. And it's not the integrated bidirectional care project that is part of the transformation work. So that's a separate pot of money. It's kind of earmarked or dedicated to help support primarily behavioral health, community behavioral health providers transition into a multi-payer environment and all the sort of capacities that are needed for that. So just wanted to clarify, I don't want people to think about that as part of the bidirectional care project. That work happens under the project incentive funds.
Thanks, Susan. Been working at the state and we talked a lot about FIMC behavioral health, and I make this assumption everybody knows what that is. Thank you. So on the next slide, what we have here is we're diving down to the $22 million, and this is just the $23 million. This is just to let you guys know what the governing board back in October of 2017 approved by allocation of the use. So where does the money go? So you see that there's partner engagement and planning, which is $12.5 million over there, almost half of the circle. And then we have domain one, which is population health workforce, about almost $6 million, or 25% of the dollars. We have 12% that goes towards Healthier Here administrative costs. And then the board also chose to do a reserve just in case if the budget or dollars have changed from the state, that we have a reserve to offset any surprises or unpleasant surprises. And then the last piece is indirect project management and domain one support, about 3% of that. So this gives you an overview of where those dollars are going towards for the $23 million that we'll be getting this year. Next slide. And then the next slide, for today we're focusing on the $12.5 million, which is about 55% of that. The dollars are going towards the Medicaid providers, about $6.2 million, non-Medicaid providers, 5.2, and then the tribes is almost $1 million. But those are the three provider groups that will be allocated the dollars out. So, so this is how. So a lot of questions we've been getting is how are you going to distribute those dollars to providers? I want to point out that this is a draft. It has been vetted at our finance committee, but nothing has been approved formally yet. And the mechanisms that we're looking at in order to send out these dollars are, the first is to complete the current state assessment, which will be more discussion later on today. And then a partner organization plan that folks will be sending in or submitted. We also want to look at Medicaid volume by providers, how many Medicaid lives are being served, and it'll be on 2016 data that we'll be using. Another criteria is what we call the partnership integration level. What this is not the business integration, that consolidation merger, but rather how do you work across provider types, whether you're a primary care physician or a primary care provider, behavioral health, and then housing and so on. And then another criteria is health equity partnership level. And what this is to address the health equity across for our clients. And we'll talk about, and this part, and also the partnership integration, both of these criteria are also being defined further with the finance committee. So we have a definition that we're going to share next month. But these are criteria that we're looking at, but nothing is firmed up yet from the definitional level. The tribal agreement is specific agreements that Healthier Here will have with the tribes to send out that almost $1 million directly to the tribes. So that's basically proviso or pay for that group. The next is early infrastructure and process changes, and what this relates to is Domain 1 activities. So and it relates back to the state assessment and say, what is it that provider need to get to the transformation level that you need to be at, and then how do we fund for that? Provider type is another area that we're looking at, and this is primarily a financial bump for certain providers that we're looking for. Again, the definition or the group of providers has not been determined yet by the Finance Committee for recommendation, so it's still being vetted. Last is the signing of the standard partnership agreement, and then that is something that we sent out, I think, a couple weeks ago, and it's a standard partnership agreement that is in the financial executive portal, and we can't change or amend that. But what Healthier Here is also going to do is draft an addendum that specifies the deliverables or expectations. And then if those are signed, and then if the providers register in the financial executive portal, that will be the last criteria to allocate dollars out. At this time, I want to say is that we are still determining the selection of the providers. So from a financial standpoint, the modeling of how much dollars, or what I refer to as a peanut butter, how you spread that across. We don't know how thick the peanut butter is, how thin it is, until we have that group of selected providers participating that will be contracted with. And then we'll be good. So as we move forward in the next month or so, we'll know more about the dollar values associated with this. But this will give you a sense of what we're looking at as criteria. And again, I can't emphasize enough, these are all draft at this point, and then more to come. So this is looking forward in the next few months, just to see how the process will work, so that you'll have a chance to see where things are going to be sliding in as far as due. So in March, as I mentioned, in February, we had a preliminary discussion with our Finance Committee on the methodology and approach. In March, I'm hoping that the Finance Committee will approve the distribution approach, and then also review and approve the contract addendum that's being drafted now. In April, we'll bring those, both the distribution or the allocation methodology, along with the contract addendum, to the governing board for approval. And then a part of the, a second activity in April will be the Finance Committee is going to approve the dollar distribution, because by that time we hope to have the selection of the providers, participating providers, and then we will be able to allocate the dollars. In May, we will bring those to the governing board and have approval payment distribution. And then the second activity is that at that point, we'll be able to send out a contract addendum to providers for signatures. In June, the contracts, which is addendums, will be signed, and then everything is registered into the financial executive portal. And then the first payment, and again, draft, the first payment I anticipate to be sent out in June. And then the second payment will be in July, and the last is in September. So there are 3 waves of payments, and it will be tied to each of those, depending on the criteria that I just explained in the previous slide. I think that's, any questions at this point? So the next part of this is just a financial executive update. I've received a lot of questions in the last couple of weeks. Just want to do a little update and also refresh, because it's similar to what you saw last month if you were here. We just submitted another batch of providers that signed into the financial executive portal yesterday. And then, so we're waiting for a match on that. Most of the folks that did not get a match with the EIN number from last month, I've contacted, I've received responses. I've resubmitted to the PCG, or the financial executor. I have not heard back yet from them yet. On the third bullet, where the financial executor is going to hold the provider training, I just got news today, just right before this, that there's thought that they won't be providing the training after all, but if there's a need for us, they can schedule a specific one. The last one is that if you have not registered, there is a survey link here that you can access and then complete the survey. Then it will load the information to the financial executor, and then it'll go through the process. And once you have a positive match with your EIN and your name, your business name, then you will be contacted by the FD, someone from the financial executor to contact you with log-on information. And then you go in there and you add your banking information and other contacts information. Okay. I think that's it. Is there any questions? Yes.
Is it required to put the banking information in right now, even though we're still in the exploratory phase of potentially partnering?
Yeah. So the question is are providers required to put in the banking information when you're still determining whether you want to be part of the provider yet? The answer is you can hold off on that. Once you enter into the survey and then you put in your information, at that point it does not ask you for banking information. Only afterward, and then you can hold a pause until you make that decision. Thank you. Thank you.
Thank you. All right. I just wanted to acknowledge and welcome Sherry Williams, who is part of our governing board, works for Swedish Providence, and also Gordon McHenry. I saw you come in, is right there. And Gordon was part of the very original Health and Human Services Transformation Panel, and then served on our interim leadership council for about a year and a half. So thank you both for attending. Really appreciate it.
You wore me out.
Yes. We tend to do that, don't we? Okay, so we're going to spend a little time now on our project portfolio and talking a little bit deeper about focusing on populations and approaches for the work. So this is a slide that those of you that were at our February meeting saw in a different format. So I'm going to say that the general idea hasn't changed, but it looks a little bit different. So on the top are the four represent kind of the four project areas that we are required to work within per the transformation toolkit set by the Healthcare Authority. But really now focus with feedback from a lot of our partners, focused more on what we're trying to do. So integrated whole person care, foundationally, that is one of the goals of the transformation project from the state's perspective. It's also a big foundational piece for us here in our King County region. Increasing safe and successful, transitions for those individuals that are transitioning from jails, inpatient hospitals, psychiatric facilities. Expanding access to appropriate services and treatment for individuals with opiate use disorders, and also improved prescribing practices around the prescribing of opiates. And then finally, expanded community and self-management supports for those with chronic conditions. So that is the sort of project-based portfolio of activities that we are going to focus on that drive our measurement accountabilities. But in addition to that, we have built into our portfolio some cross-cutting activities that really are going to lead to the success of any system transformation, we believe, in our region. And that includes community-based care coordination. So really focusing and trying to rationalize what we have in place already around care coordination, because there's kind of a lot of it, and it's very fragmented and siloed to populations, to certain organizations. So try to make sense of that, and also to bridge that out into the community, both so that community-based organizations are interacting and partnering with the healthcare delivery system in a different way, but also as a mechanism to bring in people who aren't currently in care. So we want that coordination to be out in the community as well. Addressing the social determinants of health, that's a big part of what makes a person healthy, is access to housing, nutritious food, transportation, legal aid, and so forth. And then always, as Jeff alluded to, one of our core values is equity, leading with equity, making sure that we're actually improving equity and reducing the disparities in our region. So that will be a foundational piece of our portfolio work as well. I can't remember if we had this one at the February summit or not, but this is a beginning of trying to, and again, these are still kind of works in progress, but we're trying to represent and continue to be able to communicate in a more visionary way what it is we're trying to do. And if you remember, the vision for Healthier Here is really about moving from, see if I can, oops, of course I pushed the wrong button. Which one's the middle, this the laser? Okay, there we go, see if I can do this. There it is, okay. So what we're trying to do is move the system from its current state, which is really, I mean, when you think about how we deliver care, it's really reactive crisis responses to health concerns and social concerns, and a lot of overutilization of hospitals and emergency departments and jails and EMS and fire and police. Lots of our resources go there, and so we want to move from this kind of a response to one that's much more focused on prevention, early intervention, early identification of diseases, and management of health and social concerns in a really integrated way here. So taking kind of the range of services and supports and starting to connect them through, information technology and interfaces and interoperabilities, and through this central kind of care coordination opportunity that exists. And then really, again, as part of the vision, thinking about how we transition individuals from these kinds of institutions and more restrictive environments, and also how we divert people altogether from needing to use the crisis system. So I said this before, and I'll say it again today, which is that we have this grand vision, and a lot of work and effort has been put into this over the last several years in our region through King County government's Health and Human Services transformation work, which set the stage for this, the Familiar Faces initiative work, and our Communities of Opportunity. So the Medicaid transformation project is a huge opportunity for our region, and sounds like a ton of money. I mean, how often do you get $24 million in kind of 1 month to do this great work? But it can't do everything, and there's limitations. I mean, there's federal limitations around how the waiver is structured, and of course the finances will only go so far. So I wanted to just kind of walk through and show you how kind of the ACH Healthier Here will come in and make investments in areas that tie back directly to our portfolio. So, you've heard this a lot. There is a lot of emphasis on integrating primary care and behavioral health. And so we'll be making investments, whether it be in infrastructure, technology, workforce, training and evidence-based approaches, or technical assistance to really start to improve the interconnectedness between these two things. Care coordination, that's part of, you saw that foundational piece of our project portfolio. We are going to make investments here in care coordination, workforce, community health workers, recovery coaches, peer support, information technology, all the things that help support better care coordination across the board here. We will make investments in connecting some of the social determinant, social service agencies better into the healthcare delivery system. And then we are going to focus here on kind of these crisis hospital, ED, jail, really in the transitional opportunities, although we will be paying attention to diversion opportunities, and probably later on down the line put more emphasis on diversion as well. So this is where right now I think we're starting to initially focus and think about how we make our investments. It's not to say we won't be putting money in some of these other areas later on down the line, but it's also an opportunity then for us to think about who are the other resources in our region, and how can we align and get them kind of directed so that we can get to this whole vision. Make sense? Questions? How are we doing online? Questions? We good? Okay. All right. I want to remind everybody about the core Leave Behind. So this is work that the governing board did in 2017. Again, under that idea that the waiver can't do everything, we have 4 years and a limited amount of resources. So at the end of 2021, when we look back, what do we want to say we did and how this money made a difference in our region? And so this is what the board came up with and decided on, this whole concept of interconnected HIE, HIT systems, so that providers can actually share information seamlessly across provider types and organizations. We can work off of shared care plans and really make sure that we're getting a whole person look. Making sure that people have access to person-centered, multidisciplinary, culturally competent care teams. So if we can, regardless of where a person enters the system, that there's processes and mechanisms in place to get them to a care team that can meet their needs. And then the last one is really about making sure that we're engaging the communities and the individuals that are most impacted by this work and setting up a sustainable infrastructure for meaningful, ongoing community and consumer involvement to drive ongoing system transformation. And we have a partnership with our community consumer voice group, and we're starting to, right now, we're actually hiring up and starting to build out this strategy so we can start working on that infrastructure. At the end of the day, and I introduced this slide at the February summit as well, really important to remember that from a state perspective and how what's driving this and how they've structured the waiver, it's less about the projects and more about the end result. And these are really the key end results that the state's looking for. They want to make sure that we somehow transition the Medicaid system from its current volume-based fee-for-service payment structure to value-based care. And that includes both the kind of infusion of evidence-based and best practice approaches so that the care that we're delivering we know is going to create the best outcome for the individual we're serving. But it's also about the base payment and how that happens and how you as providers get paid from managed care organizations for the work that you're doing. Moving to population health management. So you will see as the conversations evolve, more and more discussion about what are the electronic tools that you have in your organization? Do you have electronic health records? Does your electronic health record have a client registry? Do you have the capabilities to do population health management and track quality outcomes? And if you don't, those are conversations that we will be having with you to help support and make investments to help you get there and get ready for that. Providing integrated team-based whole person care. Have I said that enough yet? I feel like it's on every slide, but that is key. And defining those care teams and making sure that the care teams are robust and include kind of the non-traditional workforce that we don't always think about. Community health workers, peer support specialists, pharmacists are coming up a lot in certain situations and conditions where it's important that they become part of the team. And then the last one is linking social services to the healthcare delivery system. So we will see, you saw in Twee's slide about how the board voted in the distribution of funding that, over 40% of that funding will go to more those non-traditional community-based organizations and providers to help them link in, connect to the healthcare delivery system so that there's more seamless referring and communication back and forth. Okay. Thing. Okay, so now we're going to move into the focused population approach. But before we do that, I'll just double check to make sure. Does anybody have any questions about anything I've said so far? Making sense? Yes.
Slide back on the top. One more back. There you go. How much of the HIE system is the responsibility of Healthier Here versus the state?
So the question was how much of the HIT system is the responsibility of Healthier Here versus the state? That is a fabulous question and that we are trying to figure out on a daily basis. And even beyond that, we don't want to have 9 different HIT systems for each ACH either. So here's my 2 cents on that, and other people might have opinions. The state has been making a lot of investment and building out kind of capacities through their One Health Port system and the clinical data repository as the health information exchange for the state. It is a work in progress, and from our assessment and our conversations, I think the capabilities are there, but the getting it to work the way we need it to work as a point of care is more years out than what we have within the waiver. So we are thinking about how do we build those bridges and what currently exists in our region and how can we build off of that and expand that to get the kind of information exchange and build out that we need here in the interim until that at whatever time One Health Port can do what it says it's going to do. That said, all 9 ACHs and the state have started meeting regularly around these Domain 1 activities because A, if they're very expensive, and B, we don't want to have it 9 different ways. So continuing to think about what are we all trying to do? What are the options? How can we leverage each other and maybe make shared investments so that there's some standardization across the state? Those conversations are still in the early phases, and we will probably have some kind of hybrid model in the interim that gets us on a pathway to a statewide solution. Does that answer your question? The same, one could argue the same thing around the workforce issues too. There are some workforce things around training and technical assistance and improving capacities that we can do locally, but we are not going to, Healthier Here is not going to solve the workforce shortage that we have so much in healthcare and behavioral health, and so that's statewide strategies that need to be done. Okay, so one of the first things as we think about and consider are how we focus in on where we start with regard to populations is meeting our value and our need to address equity and reduce health disparities. And it's a balance, because if you know anything about the waiver structure, and if you've heard me talk before, you've heard me say this, which is the waiver is set up really all around the numbers, and we have these metrics, these outcomes that the state has defined, and we have to move the needle on those outcomes in order for us to earn money. This is an incentive-based program, and so if we don't hit the outcomes, we don't earn money for the region that can then go out to providers for system transformation. So we're in this constant balance between meeting our performance targets, where you need the numbers, you need the players that have large numbers of Medicaid clients in order to move the needle, and dealing with the issues of equity and health disparities and social justice, which if we just focused on, for example, if we just focused on equity, we probably aren't going to move the needle on the outcomes. And if we just focused on our targets, we probably aren't going to make the disparities worse, probably not going to make them better. So how do we take both of those things into consideration as we think about how to move this forward? And so there are some of our committees, our transformation committee and our performance measurement data committee and our King County Public Health partners have really been putting a lot of thought into thinking about this and how we move this conversation forward. Okay, I was being patient. So as a reminder, these are the metrics that we are being held accountable to, again, for the purposes of the waiver. This doesn't represent any additional measures that we as Healthier Here or the governing board or King County region might want to or believe are also important to look at. But with regard to the structure of the waiver, on the left is the list of measures that we're accountable to. In purple, you can see which projects they are attached to. And again, part of our goal was to have as much overlap as possible across our project portfolio so that we have several different activities that are driving towards better outcomes on the same measures. And then in yellow, we've built in the overlap with the managed care organization, fully integrated managed care contracts, so that you can see that you're going to be held accountable to these measures no matter what, right? So if you're going to be a contractor with a managed care organization for Medicaid, either physical or behavioral health, you will have these metrics in those contracts. And so there's really nice alignment. And so the opportunity here with Healthier Here and with these resources, one of the opportunities then is for us to be able to help you develop the infrastructure and capacities that you need to meet the targets that you're already going to have to meet anyway once you get into contracts. So really nice alignment. We're also working on, for those of you that serve, for example, Medicare clients, we're going to add that on, and you will see that there's pretty significant alignment with some of the Medicare target metrics as well. Okay, and so this slide represents the status of the project applications that went in back in November, and for each of the project work groups. So again, the structure there was a design team by each project. There was an identified population for a starting point for each of the projects. And so this just shows the initial thinking. So for example, in the bidirectional care, the idea was that they would initially focus in the primary care setting on individuals who presented with depression or who presented with an opiate use disorder. And in the behavioral health setting, they would focus on members or individuals that had diabetes. And then you can kind of go through the opioid use projects, and we're going to take the 12,000 Medicaid individuals that we know of today that have a diagnosis of an opiate use disorder and focus on them, and anyone else who has one but hasn't been screened and diagnosed yet. Chronic disease, the focus is on kids and adults with chronic respiratory diseases, including asthma, and adults with cardiovascular disease, including diabetes. So you can start to see the interconnectedness. The people in behavioral health are going to focus on diabetes, connected to the chronic disease project. And then transitional care, the jail initially focusing on SCORE, which is the South County, and then members discharging from a hospital for psychiatric or SUD reasons, substance use disorder reasons. And then high-risk members transitioning from hospitals, including older adults and people with disabilities. So that was the initial thinking back in November when the design teams had done all their work. What we are trying to do now as we move to and pivot to more of this portfolio approach is not try to, think about it, if you were a provider who wanted to participate in all 4 of these projects, and then you have to figure out, okay, who are your people with diabetes, and then which ones have opiate use disorder over here, and which ones just came out of the psychiatric hospital. People aren't carved up like that, because what you quickly will realize is people have a lot of these things going on. And so we started to think about where is their overlap, and what is that pool of individuals, or how do we start to define a pool of individuals where there's overlap that we can start as an initial focus. And what the group has come up with is kind of 2.5, kind of 3 ways of thinking about this. So the first one you're probably pretty familiar with if you've heard the term kind of hot spotting or hot spots. And that's this center dot right here, which is that small population of individuals with really complex health and social needs. They have disproportionately high use of the emergency department and hospital, in and out of hospital, tend to be heavily underserved and fragmented by the health and social systems. A lot of individuals in this group tend to be homeless or really unstably housed, for example. And this approach gives us a really nice blend of what I was talking about earlier, that blend of performance and equity, because we know if we target this population that we will be able to reduce ED use and hospitalization and some of those big metrics. And a large majority of this population also experiences a lot of health disparities, so we'd be addressing equity. So we would put some attention there, but then realizing that that's a relatively small place to start, that there's also this kind of surrounding area, what Eli calls the warm spots, of, again, individuals with overlapping needs and illnesses and chronic diseases. And we would have to define that. But then the missing population that we hear a lot about, every time I'm in a conversation about high utilizers or hot spotting, we hear more and more, what about the people who actually aren't using the system and need to be, and those individuals that are being missed? And that's this concept of cold spots. And so these are again, the individuals that are not utilizing or they're underutilizing the traditional healthcare system. They're not going to preventative primary care appointments. They're not going to their behavioral health appointments regularly, and so they end up going to the ED, waiting till they get really ill, going to the ED or using the emergency department inappropriately. Those groups are of individuals who are underrepresented in our hot spotting. So there's certain issues that we might want to focus on, like reproductive health, that don't show up in the metrics because we didn't select that project in our portfolio, but we might want to consider them as part of our focus group. And for an example, and this is what we're going to test a little bit with you guys today as we dig further into this, under hotspots, kind of broadly, you have individuals, Medicaid members that are with high utilization of emergency department, hospital, under jail. And then you kind of further narrow that to people who are visiting the emergency department or hospital because of behavioral health conditions, or individuals who have poorly managed chronic diseases. And then there's a series of questions that we can ask of that data to further understand who these individuals are, what their needs are, get a better sense of that. We do the same thing with the kind of cold spot population to focus in on there. So we'll spend some more time with you guys thinking about, does that make sense? What questions should we be asking of the data in our small groups in a minute? But before we move on to the next thing, I'll just take a pause and see if people have questions about this or about this approach. All right, clear as mud, right?
On the web, one question, what is the rationale for using the 2016 data versus current data?
Okay, so the question is, what is the rationale for using the 2016 data versus the current data? And is that specific for the target population or TWE's comment about using the 2016 data? Because I can answer for TWE and then maybe Marguerite wants to answer the other one. For using it for the financial modeling and the volume, it's because that's what the state is using. It's the they're using November 2016 Medicaid enrollment numbers for the entire foundation of the payment structure for the waiver. If it's for the population health stuff.
It's because it's the only data that we actually have to work with. There's a long time lag, about a 9-month time lag in which we would get Medicaid claims data. So that's why we're working with 2016.
Great, so the answer for this is, I'm repeating for the people on the webinar, it's for the data around the actual demographics and client utilization. It's because the 2016 data is the most complete data set we have. There's a very long lag, 9+ months in terms of Medicaid claims data. So we don't have a full data set for 2017 claims yet. Any other questions? Okay. It's gonna be my nemesis, okay.
And how are we doing on time? 2:24. And what time is it?
Yeah.
Okay.
Okay. Okay, so we're going to talk a little bit about the evidence-based approaches. And again, the parameters for this are set in the toolkit that was developed by the Healthcare Authority and defined by projects. The design teams that met last year had some role in being able to kind of narrow and make determinations about which approaches they wanted to focus on by project. So you can see that this is by project, and the evidence-based approaches are best practice approaches that have been identified by the project. I'm going to go into these in a little bit more detail right now to remind you, or for those of you that these are new and you don't know what's all involved in each of them, to just give you a little bit of a context, because part of what we need to do now as we go back and think about implementation was, did we get it right? Is this really what it meant? What does it actually mean to do the collaborative care model? And do I, as a provider organization, primary care clinic, really want to do that? Again, this is a repeat slide from our last summit to remind you of the objectives of the bidirectional integration of physical and behavioral health care. Really, it's about improving access to behavioral health and primary care, and improving access to primary care for individuals being seen in the behavioral health clinic. This slide you also saw last time kind of breaks down the evidence-based approaches by setting and population type. So you have, these are the 3 evidence-based approaches, and you can kind of define where you fall by the setting type. So the BREE collaborative behavioral health integration recommendations are really for individuals being seen in a primary care setting where there is some episodic behavioral health condition, periodic depression or anxiety, kind of more mild to moderate, that pops up every now and again for a person. The collaborative care model is best implemented for individuals who are seen in a primary care setting but who have more chronic behavioral health conditions. And then the enhanced collaboration is really built off of SAMHSA's, the Substance Abuse Mental Health Services Administration, definition and continuum of levels of integration. And it's really designed for community behavioral health centers and people that are being seen that have either a serious chronic mental illness or a significant substance use disorder. But foundationally, what I would say about these 3 models that underlie all of them is a team-based approach to care, measurement-based treat to target, so it's very specific, using evidence-based approaches, and doing population health management. So if you are a primary care setting, provider organization, or community behavioral health, you need to be thinking about those things. Do I have those capacities today? Do I do those things today? And if not, what do I need to get there? The transitional care project, again, this is not new. The goal is to improve transitions for people coming out of more restrictive settings like hospitals and the jail and psychiatric facilities. And there are actually 3 different approaches that have been identified that apply to each of those populations separately. So for Medicaid individuals who are transitioning from prison or jail, there is a community reentry approach, the APIC model, which stands for Assess, Plan, Identify, Coordinate. It's a set of kind of key elements, key activities that get implemented. The Peer Bridger program is an evidence-based or best practice approach for individuals transitioning from psychiatric facilities, uses peer support specialists and recovery coaches, and provides a series of core activities or elements that they do to help support that transition. And then the Care Transitions Coleman model for individuals transitioning out of the hospital. So again, this is what the design teams defined. We'll spend some time today, and there will be ongoing work to say, is this what we really meant? What does that mean to do the peer bridgers? What does that mean for an organization if I want to engage in that and develop one of these programs in my within my organization? Addressing the opioid crisis. So this actually has several activities under it that include improving prescribing practices for physicians and dentists and other individuals that prescribe opiate, for example, pain management, and then increased access to treatment, overdose prevention, and implementing recovery coaches. So we're only going to focus on the access to treatment. Things being tested now. The opiate design team talked about a number of approaches to this that vary by setting, but with the main goal of increasing access to medication-assisted treatment, whether it be methadone or primarily buprenorphine, which is very hard to get access to right now for a lot of reasons. And there's a number of different ways that clinics can do that through like the opiate, the OBOT, which is office-based opiate treatment, and the hub and spoke model. And so some further refinement needs to be done on this. But I think the main message from the opiate design team was that primary care clinics and other settings should pick the model that works best with sort of their workflow and their clinic and their goals and values. So there's some flexibility in here in terms of, there might continue to be some flexibility anyway in terms of options and choices. And then the chronic disease prevention and control project. And this one is built around the chronic care model and is more, again, like similar to the bidirectional integration, a series of activities. Again, lots of overlap, team-based care, adding kind of a non-traditional workforce around community health workers, population health management, client registries, strategies, and so forth. And then the self-management support, so evidence-based like diabetes prevention programs and things like that that would get implemented or improved access to those programs that already exist within our community organizations. Okay, so that is what the toolkit tells us, the sort of have-tos with regard to the approaches that we use by project and by strategy. A couple of words that I'll say, and we don't have total clarity on this yet, but we're hoping to get it, which is like how rigid and stringent do we have to be around some of these evidence-based approaches, and is that the only thing we can do? Well, the short answer to that is no, it's not the only thing we can do. There is room within the structure of the waiver for us to do some more innovative things that weren't captured or weren't available to us in the toolkit across the different domains. But we will have some requirements around building out and training and technical systems around some of these approaches. And so how that will look is yet to be defined, and we will continue to have that conversation as we learn more from the state. We're waiting on them for more information about the reporting requirements and what we'll have to do around the evidence-based practices. So I'll take a pause there and see if people have questions. Gordon, yeah.
In terms of guidance from the state, is that something that is King County Healthier Here specific, or is that guidance that will apply across all 9 ACHs?
So the question is when we get guidance from the state, will it be Healthier Here specific or apply across the state? And the answer is it'll apply across the state.
So we're not the only one asking.
No. Any other questions? Okay.
I got one.
Yeah.
So on the opioid goal there, can you talk about why the Healthier Here is just focusing on the one part of it?
Oh, thank you. So the question was on the opioid strategies, why Healthier Here is only focusing on one part of it. We're actually not, so I apologize for not communicating that more clearly. In terms of like the defined evidence-based approaches, that's what we're talking about today. We will be focusing on prescriber practices, but actually that's so prescribed by the state that it's really, I mean, the goals there for the prescribing practices will be to get providers to start prescribing in line with the state and national guidelines for opiate prescribing and incentivize provider organizations to link their electronic health record to the prescription monitoring program. And that's pretty much the work that will happen for that one. The overdose prevention stuff is the distribution of naloxone kits, and there's a lot of that going on in King County right now through the behavioral health organization, so we will align with them and do whatever we need to do to kind of enhance that, whether it's expand it or, help with the trainings and stuff. So yeah, so we will be doing, yes, thank you. No, thank you for that clarification. We will be doing all 4. Actually, we're required to do all 4 even if we don't want to. But I just put the treatment approaches up there today. Yeah.
So when developing partnerships and entering into this now and having these conversations, where is the flexibility? I know you're asking the state a little bit for the flexibility on the implementation of the evidence-based practices. Where is your flexibility on the implementation? Are all partners going to be required to do whatever the outcome is on that flexibility of the evidence-based practice? Are they going to be required to do one of these evidence-based practices? And what about the other kind of flexible funds around equity, social determinants of health? Where does that come into in practice with funding some of the interventions and the actual services being delivered?
Yeah, so let me try to repeat that. So the question is, where is, so kind of a 2-part question, where is Healthier Here's flexibility or vis-a-vis the sort of partnership relationship with provider organizations, their flexibility in what kinds of transformation activities they can do? How, basically, I think the long and short of it is how much do we have to stick to the evidence-based approach or can we do more innovative things or choose other things? And then the second part is, where does the social determinants of health work fit in and what does that look like in relationship to the project portfolio? Does that kind of summarize? So with regard to your first question about the stringency around the evidence-based approaches and do you have to choose one, that's the piece where we're still trying to get a little bit more information. But what I think will be that, and if I were a provider organization, I would be honing in more on kind of what are the key activities and less on the specific model. Like, what do I need to have in place to do population health management of populations, whether it be chronic disease or individuals with behavioral health? How do I just do general population health management? What do I need to do to build out integrated care teams? And more importantly, what capacities do I have to transition to value-based care and what do I need to put in place? And then I would also be thinking about what kinds of training and technical assistance do my direct service providers need that would help them deliver better care. And in doing that, I think we'll be able to connect it to these evidence-based approaches. What I don't know, and this is what we're waiting on because this will be the sort of deciding factor for us, is the pay for reporting requirements. So the draft that we saw about a week and a half ago was a little bit concerning because it really did have providers reporting all the way down at the provider level, how many people were trained in the Coleman model, blah, blah, blah. And that is not what we want, and we've given that feedback pretty strongly to the state. So we're hoping that they will take that and kind of move off that a little bit and create more room for innovation. So, is that, I know that doesn't fully answer your question, but, and I will say again, that even if we have to like really adhere strongly to these evidence-based practices the way it's laid out in the toolkit, that doesn't mean we can't do other things too. And so we will be sort of looking at, because at the end of the day, we get paid based on our outcomes. And so we have, and the state has said this in other venues, that, you know, how we get to the outcomes, there's more flexibility there, and it's up to us. So I think we'll have flexibility there, but the how we have to report is the kind of the stickler on that.
Yeah, I think that was probably the question around the social determinants of health was, for some of the smaller providers of social service, so, you know, looking back at the diagram and the housing, transportation and such, the desire to engage those social service providers, they're not going to have electronic medical records. You know, they're not going to have that level of capacity. And to be able to get in and address those desires of equity and access, what is the intention? That's kind of my question around that flexibility.
Yeah.
So what's the intention around Healthier Here's investments to support kind of that social service, non-traditional primary health or health delivery system that maybe is outside of some of these evidence-based practices?
Yeah, so thank you. Yeah, so the question is, what is our intention around really supporting and working with these non-traditional providers? I think you saw from Twee's slide that over 40% of the budget is dedicated to go to those providers. We are just starting to embark on a process. So you're going to hear about the, like, for example, the current state assessment today for healthcare delivery system providers. We're going to do a similar kind of thing with community-based organizations and start to work with them to see what kinds of capacities and infrastructure needs they have to help them engage with the delivery system. And then it's getting everybody in the same room. And part of the current state assessment that we'll be doing, even with the healthcare providers, we will be asking you, who are your community-based organization partners? Do you have housing partners that you refer to or work with, or food nutrition partners to start to? And if you don't, we're going to kind of work to build those relationships. And then we do have resources dedicated to that provider type. So that's one way we will do that. The other thing that we have is, so the board has approved, and you didn't see it in the 2018 budget because it doesn't come into play until 2019, but we are going to establish what we're calling a social equity and wellness fund. And so a portion of our incentive dollars that get earned into the region will go into that fund, and that will serve as a mechanism to invest more in social determinants of health and those community-based organizations and kind of the things that we know Medicaid will never pay for. And our hope is to continue to build that, get other investors into that, and really grow that fund so that we can focus some energy there. The Finance Committee is just starting work on kind of defining what that will be, how we'll use it in the criteria. And like I said, we'll start putting money into it in 2019 incentive funding. So does that answer your question? What else?
Yeah, just a question. I mean, part of the success of what we got here is to identify the population for the different segments. And I think from my experience, we have very robust ways of identifying the hospital, the regular hospital for visits. But from jail and from behavioral health hospitals, that is more challenging. And I was just interested to hear if there is some work that's been done around that and some tools identified.
Yeah, thank you. So the question was around, we have pretty good systems in place to identify people when they're coming out of a regular hospital, but when they're coming out of jails and psychiatric facilities, less visibility into that. We are working on mechanisms to sort of pull that together. That will be some of our HIE, HIT investments. Will hopefully kind of build off that and give us opportunities to be able to create flags and create mechanisms for making that more visible. We have access to the data right now, so we can match people. What we don't have is a mechanism for a provider to be notified. I know the Behavioral Health Organization does that with their behavioral health providers that are in their network for behavioral health clients that so they'll get a notification when somebody is booked into jail, for example. But the larger system that doesn't exist. So that will be part of the conversation. That's part of the kind of the innovation and the opening this up. And when you think about whole person care, I think the other thing that will open that up a bit is when they financially move into the fully integrated managed care finances, and it lives under the managed care organization. All of it, I think that the healthcare providers will have a little bit more visibility just by virtue of that happening, but probably not the total of what they'll need. Marguerite, would you add anything to that?
So I guess what I would add is, I do think we have tools like PRISM, which you might be familiar with in the behavioral health system. So an ability again to generate, and also with connect with providers on the individual notifications, but also an ability to generate lists of folks. I think where we really lack is actually when folks need care that are not coming in through sort of traditional providers. And I think that's going to be a real challenge for us, and part of thinking about the domain one HIT/HIE work. One of the big challenges is not only what connections do we have around kind of and data sharing around traditional providers, but then how do you get out to those sort of other community supports or resources or agencies that might be touching some of the lives that we hope to benefit from the Healthier Washington work.
So I'm going to, in the interest of time, throw this over to Gina now, who is our Chief Operating Officer for Healthier Here. And she is going to move us into some further discussion. So this is great that we kind of got it going and to dig a little deeper into the implications of some of the stuff we just talked about.
Great, thank you. Hi, everyone. Also, folks online. This is the portion of the afternoon when now we have an opportunity to hear back from all of you who've been sitting here patiently taking in all this information. And I just want to say that we started doing this at our last partner summit, and we've got a lot of really great input from folks here physically in the room, as well as people on the webinar. We circulated some of the notes from that because we're in the process of having this kind of cascading engagement with committees and stakeholders. All of this is like an iterative feedback loop. So your input is actually very valuable as we're continuing to think through. Clearly, there's certain things that we know. There's lots of things that we're trying to define. We're really trying to create some structures to hold, understand what the guardrails are, how much flexibility we have, and so forth. So getting community input is really important to us. This part of the agenda is where we are going to break up into some groups. So you'll see we have two primary groups. I'd love for, just by a show of hands, how many here, and maybe for those of you online, you can identify yourselves as being in what we're calling traditional Medicaid providers, hospitals, health systems, managed care, behavioral health, community health centers. Just by show of hands, who represents that? Okay, great. And then who would call themselves a non-traditional provider, community-based organization, social service organization? Okay, great. Well, I think it'll probably work for us to divide in this room into two groups. And what we'll do is we will have, maybe we'll have folks with the traditional Medicaid providers in that back corner, kind of going around that large Post-it note board there. And then we'll have the non-traditional, non-Medicaid provider organizations over where Sherry is standing by the chairs. And you can actually just, we'll have you guys move in just a moment. But essentially what we're going to be doing is we will have a Healthier Here staff person to moderate the discussion. But we also want you all to decide who in your group is going to report out, because we would like for everyone to be able to hear the input from folks from different sectors, different provider types, in terms of the questions that we have. So we're going to talk about the two main questions. We'll have a staff person scribe on the flip charts and to capture some of the key points, and then we'll have everyone report out probably in about a half an hour. I think we have that amount of time for this. So essentially this is getting to the actual questions. Let me just talk about both of the questions before you guys divide out. But as you noted, we were talking previously about focus populations, target populations, as the toolkit describes. So there are obviously different ways to define populations. You saw what the design teams came up with in the fall in terms of focusing on how to move metrics in certain kinds of categories. You heard about hot spotting and cold spotting. What do you think is important for us to consider as we go about choosing a focus population? What would be the best focus population or series of focus populations from your provider type perspective? And then what does your provider type need to identify an initial group of Medicaid members to move forward with transformation? I think this is a data-oriented question. What kind of information would you need to be able to identify Medicaid members? So that is a series of questions around how we should be focusing or thinking about populations for the projects. Secondly, we talked a little bit about evidence-based approaches. We talked about the fact that we have a certain set of prescribed approaches that the state has given us. What would evidence look like from your provider type perspective? What is important to retain from evidence-based practices and what can be modified? And what does your provider type need to implement evidence-based practices in ways that reflect healthier care values? So, clearly these evidence-based approaches were developed with mainstream populations in mind. How can we spur innovations that help to close the racial and ethnic inequities in King County? So that's the kind of input that we're looking for from you. We will focus first on the populations question, and then I will have you guys kind of transition to the next question about halfway through. And we will also, just for folks who are on the webinar, we're also going to have Melissa here moderating a discussion around these two questions amongst you as well. And just note that when you are inputting your responses to questions into the chat box, we're actually saving those and using those for our notes as we're capturing all of your input. So why don't we at this point break off into our traditional Medicaid providers and our non-traditional, non-Medicaid providers on this side of the room. And if we could have, let's see, would we like, I'm going to enlist Marguerite's support to help facilitate the group that is meeting over here. And I'm going to ask for Susan. And Susan, if she's still here.
I'm behind the pole.
Oh, she's behind the pole. And then what we'll do is maybe Tavish, do you want to go? Which side do you want to go to? Yes. Okay, I'll go to this room. Great. All right, I think we're set.
To these questions, sorry. Make sure
So I know folks are having great discussions around populations. I want to have you guys try to wrap up those conversations quickly and move on to the next series of questions.
I got batteries.
I will flip the slide shortly. Go back to talking.
Is it, the things here, I wonder if it's low on battery or something like that. Or if we lost it. Let me just turn it on and off.
Should I just move down this
You
way?
could do it.
Does that work? Some kind of news thing that.
No.
Not batteries, but
Who already are touching their systems.
What the heck?
Stuff.
why is it not moving here either?
They actually might be
Unable to hear.
laboring here, but right now.
Oh, yeah. What'd you do?
I don't know.
What's green now?
Okay, evidence-based approach after changing batteries in the pointer is now posted. So we're gonna try to wrap up this conversation. I hope you have appointed your spokesperson who will go like lightning through some of your high-level points. And then we actually have just a few additional updates that we wanted to provide to you all before we close. So let us go to the non-Medicaid, non-traditional provider group first, and I'm going to ask your spokesperson to use the microphone here. Come up here and use the microphone so that people who are on the webinar can hear what you have to say.
Yes, okay, this is Tavish Donahue reporting for the non-traditional provider group. Some of our highlights from a great discussion on target populations. Some of the most important considerations are, if we're going to define one single target population, even if that's fairly broad, hot spots, cold spots, warm spots, who gets left out. The fact that folks with limited English proficiency are often left out of some of the pilots and mitigation work going on in our community already, so we don't want to repeat that. And there's also populations with the greatest needs, folks who have physical health challenges and also challenges around social determinants. And my handwriting. Different diverse categories. So folks who maybe have asthma, but they're not hitting the high PRISM score as some other high-risk individuals, so they're not getting the additional supports they need. They're kind of flying under the radar for various reasons. Another consideration, perceived access versus actual quality of care. As some populations may kind of be, you check the box, they have access to all these services, but are those high-quality services? And are they meeting their needs and getting them to where they need to go? And another very important consideration, reaching people in the home, community, where they are, instead of expecting folks to come into the clinic, deal with transportation issues, childcare, and then when they don't show up for their appointment, they're just left out. Okay, some ideas on best focus populations. Anyone in jail. We had some good statistics from the SCORE jail. So about 80% of the folks coming into SCORE have to be detoxed. And 238 out of 600 have chronic conditions. Gordon made a great suggestion about youth leaving incarceration. We want to be sure we're not focusing too much on adults, leaving out kids, teenagers, those groups. Another potential focus population, folks who have barriers related to the social determinants. This was a great suggestion from Sally from the YMCA. Folks may hear about, oh, just improve your diet, exercise a little bit more. But some folks have big barriers to even making those, lifestyle changes that are easier for folks who have means, have stable housing, support system, etc. Yeah, some other potential focus populations, the foster care system, immigrant and refugee communities, communities of color, and also the elderly and disabled. People who don't quite meet the requirements for being institutionalized, so they're still living at home in the community and kind of have scattershot services. They're not able to really connect and build a relationship with some of these care providers who are in and out. Folks who are socially isolated. But we learned that we could kind of get a head start on identifying those folks through Access and HerbReview, also HopeLink. And another great suggestion, rural communities. Okay, moving on to evidence-based approaches. What needs to be modified in some of our prescribed approaches from the Healthcare Authority. Make them more culturally competent, so not just linguistically competent, but culturally competent. We had a suggestion that we can reach out to different cultural communities and kind of superimpose approaches onto these prescriptive, more westernized approaches. A way to do that, we really need to get into the community, build trust, kind of get ambassadors from the community to start taking on that work. Another great idea that provides some technical assistance to those community members, get them trained up in those approaches, and then maybe they can become leaders, trainers, really spreading that into their communities. And also a couple messaging with the knowledge of barriers and access to resources. Just because you're putting out a flyer, advertising something on a website, and you think, oh, we're making this available, it isn't necessarily available to everybody. And I want to close with a discussion we had about surveys. So when we're encountering a client, a patient, and if we don't have access to something like our proposed shared care plan, we may be going through the same set of questions with them that they've answered 10 or 20 times. And that experience is really dehumanizing. If we're putting them on the spot, making them work through some painful experiences just so we can say, oh, now you qualify for these expanded services. We need to think about doing that in a more sensitive way. Okay, and as we wrapped up, we were talking about some needs related to applying these evidence-based approaches, additional capacity, providers, and access, so fast-tracking folks who really need help.
Thanks, you guys. We're going to transition very quickly to the traditional Medicaid provider group.
And we're gonna roll this way up, folks, so I apologize if your details are lost in this. I think really at the end of the day, what we were talking about is having the tools, and really I think what I heard from our group was really the need for the domain one investment, and an idea, for instance, if we're gonna use pre-managed to manage population health, everybody actually has to have pre-managed. But that assumes that you've got a population who's already touched the ED and who also is accessing healthcare services. So the bigger question is, as we look at cold spots, how else are we identifying those populations? And so how do we know where they are? One example was thinking about the folks that are in adult homes. Those could be individuals who would fit neatly in a cold spot, or potentially it could be a hot spot. So how do we get that data? And then who's responsible for reaching out to the cold spots and getting those folks engaged? So moving on to the evidence-based approaches, I think we heard a lot of similar things, which is that the evidence-based approaches don't, are sort of general and don't fit for necessarily the populations that we're serving. And in fact, there are a lot of different evidence-based practices and approaches that folks are using to meet populations as to what their needs are. And so it may not be fidelity to an entire model, but in fact that we have different components that meet different needs and different clientele. The last thing I would say is a note just on paper reporting metrics like training. Sure, okay, we can send a provider to training for 2 hours. Does it mean that they're an expert? Does it mean that we're going to apply the entire model? Maybe not. So really an opportunity for us to think through what might be more meaningful. One idea that I think that was raised was this idea of triaging, really triaging so that we know with populations in different panels, for instances, or different groups. So high chronic disease need, it could be a dementia group, it could be something else, that there might be different requirements or different evidence-based models that apply to different populations. Obviously, the more complex they are, it sort of becomes an interesting job in figuring out what that looks like, about what works best for folks. But really thinking about trying to meet providers where they already are versus asking them to jump through hoops that just for the sake of counting numbers.
So since you still
Oh, and I still have the mic and it's my turn.
Okay.
Current state assessment, I know you're all dying to know this information. We are required by Healthcare Washington to conduct a current state assessment. The idea is that this helps to inform the implementation plan. I want to share with you sort of the approach that we're taking to the current state assessment. One is that we've got 3 surveys that are being developed that will be launched. One is around for healthcare and behavioral health providers. The second one is for community-based organizations and social service agencies. And the third one is health information technology and health information exchange. That is a separate one because we also know that within your organizations, it makes more sense to make sure that we also get your CIO or the CTO in addition to the provider perspective on information exchange. But when we think about the current state assessment, we have a lot of other information that we've already gathered or that is available for us to be thinking about. One that is not listed on here is a 2017 survey that was conducted by the Community Consumer Voices group that is part of Healthier Here. There is a new King County Hospitals for a Healthier Community 2018-2019 Community Health Needs Assessment. We've done a soft launch of that, not a hard launch of that, but this resource is just becoming available. We have conducted a regional health needs inventory that many of you will remember that was part of our plan that we submitted last fall. Familiar faces for those of you, I hope that most of you are familiar with that project. It is in fact looking at high utilizers, people who enter the jail multiple times a year, also who we know have many mental health and behavioral health conditions as well as chronic disease conditions. A large community group who's been involved with Familiar Faces went through an exercise of what does the current state look like in the environment, showing where connections around coordination is happening or is not happening, and where we want to move to a future state of being a more efficient, a more organized delivery system for that population, as well as other community assessments. So when we've been thinking about the current state assessment for our healthcare and behavioral health providers, we're starting with the end in mind, which is delivery system transformation. So what we're trying to figure out is what information would be helpful to assure the success of the overall and project-specific transformation that we hope to achieve. And so we've been working with other ACHs, we've been scanning the literature, we've been pulling from and reaching out to different folks who've been on the different design teams to actually help pull that information, thinking again that the ACH, Healthier Here, is really working with you all at the provider organization level versus at the clinician level. So primary reasons, again, for conducting the current state assessment, we want to increase our knowledge, our collective knowledge and understanding of the context and environment that we're working in. It should help inform our implementation plans and importantly, the investment strategy of Healthier Here. It meets state's requirements and it helps us all hopefully make better informed decisions. This is a timeline. Importantly, what I would say to you is that where we are today is we are working this week on finalizing content, getting input in, and really defining the audience. And that beginning sometime in the next week or so, we will be sending it out to organizations. At this point, for those of you who are healthcare or behavioral health providers, what we will be sending that information out to whoever you have identified previously. If you have already fulfilled or submitted one of the provider surveys that we had originally done, we asked you who was your legal contact for your financial information, as well as for most part, we know also who your sort of program or administrative lead is. So we will be reaching out to those people. So for instance, if you are a large health system and you have multiple hospitals, we will be reaching out to, for instance, Sherry at Swedish, as well as your financial person, and we'll ask Sherry to distribute it to her different hospitals to get that information and to roll it back up for this survey. Same thing for the FQHCs. For behavioral health providers, we'll be working with the BHO again, who will help make sure that that information gets to you. And if you have put your name and identified yourself as a healthcare or behavioral health provider, and you submitted your the provider survey that was originally conducted. We have your information, and we will be sending this survey to you as well. So what the survey covers, general information about your organization or agency, issues such as quality improvement, care coordination, a little bit on workforce, culturally and linguistically appropriate services, value-based payment, and then project-specific questions. So that was really super fast. Now I'll take a breath and see if folks have questions. Wow, that is impressive, no questions. So let me also then reiterate a couple of points. The survey, I am hoping, is going to come out electronically to you next week. And this is not for your CBOs or social service agencies, this is for your healthcare and behavioral health providers. So you should be getting it next week. You will have approximately 3 weeks to work within your organization or agency to fill out the information and get it back to us. That's what we're hoping. For those who are with community-based organizations and social service agencies, we're going to be continuing to work with our Community and Consumer Voice Committee, as well as many of you, as we refine our strategy for making sure that those community-based organizations who are interested in engaging will be able to get that survey, as well as making sure that we have the appropriate level of questions and the appropriate questions for those community-based organizations. Wow, no questions. Great, thanks everyone.
All right, so I am here to wrap things up. I just wanted to acknowledge for the folks who participated in the webinar, we got a lot of responses and input into our small group questions. We really appreciate your input. We will be adding those to the summaries that we're putting together for today, as well as the written notes from our 2 groups here in the room. And following tomorrow, hopefully tomorrow first thing, you will be receiving through email a survey. We'd love to understand how we're doing, and if there is information that you feel like you need, other input that would be helpful for you. You will also be getting in the next week or so the summary of our small group conversations, and as well tomorrow we'll be receiving the PowerPoint that we used today, so you can share that, keep that, reference that. Obviously the PowerPoint also has the link to the provider survey where you can enter your organization's EIN and financial information if you know at this time you want to be involved with us as we move forward. And then next month, same bat time and same bat channel. We are continuing to meet here. Note that the content is evolving. We're not just doing one straight set of presentations. We are continuing to evolve the information that we are sharing out to you. So we will continue to engage you in the questions that are relevant next month, and also share out information based on new information that we get, and key decisions that we're making, etc. So we look forward to seeing you next month. Thank you all for being here in person and for being available to us on the webinar, and wishing you a wonderful sunny afternoon in the area. Thank you.